Lisfranc injury, tarsometatarsal fracture dislocations. Epidemiology. Tarsometatarsal fracture dislocations are commonly missed, and early diagnosis is critical. Anatomy of Lisfranc joint. The Lisfranc joint complex consists of three articulations: tarsometatarsal articulation, intermetatarsal articulation, intertarsal articulations. Stability of the Lisfranc joint. Bony factors. The second metatarsal fits into the mortise created by the medial cuneiform and the recessed middle cuneiform, forming the keystone configuration. Ligamentous factors. Lisfranc ligament runs from the medial cuneiform to the base of the second metatarsal on the plantar surface. Plantar tarsometatarsal ligaments. Ligaments between the medial cuneiform and the second and third metatarsals. Dorsal tarsometatarsal ligaments. These are weaker, leading to dorsal displacement of bones with injury. Intermetatarsal ligaments, located between the third and fifth metatarsal bases. Columns of the midfoot. Medial column includes the first tarsometatarsal joint. Middle column includes the second and third tarsometatarsal joints. Lateral column includes the fourth and fifth tarsometatarsal joints, most mobile. Mechanism of injury, aviator or horse rider. 1. Twisting, forceful abduction of the foot on the tarsus. 2. Axial loading, compression forces on the foot. And 3. Crushing, high-energy impact injuries. Clinical presentation, C.P. Instability test. Grasp metatarsal heads and apply dorsal force to the forefoot while palpating the TMT joints. Dorsal subluxation suggests instability. Imaging. X-ray, AP, lateral oblique, and weight-bearing views. Stress views may be used to detect instability. CT provides detailed images of the injury. MRI, useful for soft tissue injuries or ligament involvement. Bone scan may be used in some cases to assess bone involvement. 5 critical radiographic signs of midfoot instability. Disruption of the line from the medial base of the second metatarsal to the medial side of the middle cuneiform. Widening of the interval between the first and second rays. Misalignment of the medial side of the base of the first metatarsal with the medial side of the cuboid on the oblique view. Dorsal subluxation of the metatarsal base on the lateral view. Disruption of the medial column line, a line tangential to the medial aspect of the navicular and medial cuneiform. Classification. 1. Quenu and Kuss classification. Type 1, homolateral, all metatarsals displaced in the same direction. Type 2, isolated, one or two metatarsals displaced from the others. Type 3, divergent, displacement of metatarsals in both the sagittal and coronal planes. 2. Meyerson classification. Type A, total incongruity. Type B, partial incongruity. Type C, divergent, lateral, medial, dorsoplantar dislocations. Treatment, TTT. 1. Conservative. Indicated for sprains, non-ambulatory patients, or peripheral neuropathy without instability. Method. Short leg cast for 6 to 8 weeks. 2. Operative. ORIF, open reduction and internal fixation, for bony fracture dislocations and ligamentous injuries with instability. Arthrodesis, for purely ligamentous injuries and delayed treatment with chronic deformity. Surgical approach. Incisions. 2 longitudinal incisions, centered over the intermetatarsal spaces. 1 incision over the metatarsal. Reduction. The key is correction of the second metatarsal base dislocation. Fixation. Screw fixation for the medial column. K-wires for the lateral metatarsals. Intercuneiform screws for intercuneiform instability. Complications. Post-traumatic arthritis. Non-union.